In this lecture, we're going to examine what the question should be in the clinical trial, what the response measure you will use to answer the question, and in what population will this trial be addressing. You may recall that in our previous lectures, we examined some of the background issues, including the traditions, history of clinical trials, the regulatory issues, the ethical issues, and how they impact clinical trial applications. We also examine why we do clinical trials. How does a clinical trial methodology fit into the general clinical research enterprise? How does it relate to observational studies and basic research? So now let's examine how we would define the question in a clinical trial. We have many questions we'd like to examine in any research enterprise, but in a clinical trial, we force ourselves to sort of prioritize them into a primary question and a secondary question, or a series of secondary questions. The primary question is the one that we feel is the most important central question, the one that we would use to decide whether we're going to use the intervention being tested or not. Ideally, we only want one primary question for reasons that will be evident as we examine the sample size estimation lecture. We need to have the question stated in advance. One of the flaws is if you conduct a study, examine the data, and then after you've seen the data, decide what the question is, you are prone to make more false positive claims than would be desired. So the primary question, it really is the basis for the trial design and the sample size and many other things. Of course, we're not going to conduct this trial just to answer one question. We have a series of questions we want to ask. Some of those questions may be related to the primary. We need to state them in advance. And again, we want to try our best to limit them in number. The more questions we ask, the more statistical analysis we do, the more likely we're going to find something by chance alone. As an example of defining the question, let's look at the physician's health study. This was a study of aspirin versus placebo. It had a primary outcome of total mortality, a secondary outcome or a secondary question of did aspirin compared to placebo reduce the incidence of fatal and non-fatal myocardial infarction. The Eastern Cooperative Oncology Group, a large cooperative group that conducts cancer trials, one trial, in this case ECOG 1178, compared tamoxifen versus placebo. The primary question was whether tamoxifen reduced the incidence of tumor recurrence and relapse and disease-free survival, that is, alive without the cancer recurring. Of course, the secondary question, an important secondary question, was did tamoxifen reduce mortality? Another example is the intermittent positive pressure breathing study, a study of patients with chronic pulmonary disease. This trial examined using a long-term intermittent positive pressure breathing device versus a very simple handheld nebulizer. In this trial, the primary question was whether this device plus bronchodilator would improve the forced expiratory volume in 1 second, a common pulmonary outcome. A secondary question was whether it would improve quality of life of the patients. Sometimes there are surprises. An example of this is a trial called AHEFT, which was published in the New England Journal in the year 2004. This was a trial of over 1,000 African Americans with class 3 and 4 chronic heart failure. A combined therapy was to be compared versus placebo. Both of the components of the combined therapy were well-established drugs, but no one had tested them in this combined fashion in this population. A new outcome was defined, a composite outcome, which we'll discuss later, that included death, heart failure hospitalizations, and change in quality of life. This trial, however, was stopped early because of an unanticipated mortality benefit that was not pre-specified. So sometimes you have an idea of what the trial was designed around, but something unexpected turns out, in this case, mortality. Here, for example, I've shown you the mortality survival curves for the two therapies, the placebo versus the combined therapy. And as you can see, after about 200 days, the survival experience tends to separate. And in fact, it was statistically significant, so much so that the trial was terminated early. If you looked at the endpoints, the composites of this study, the primary composite score, was also significant. But the trial was stopped early because of the second line, death from any cause. You also notice the time to first hospitalization for heart failure was also significant, 16.4% versus 24.4%. And finally, the change in quality of life score at 6 months was also significant. So not only was the overall composite score significant, but each of the components. But the primary endpoint was not the reason it was stopped early. It was, in fact, death from any cause. Having decided what the primary and secondary questions are and prioritize them, we also know that we want to examine subpopulations of the study. So we will naturally have questions about the effect of the therapy in a subpopulation of subjects that were entered into the trial. We also want to assess the internal consistency of the results. We may want to confirm a previous hypothesis that some other study has raised, or perhaps we want to generate a new hypothesis. So subgroup questions are an important part of a clinical trial, group questions, but we also recognize the more we do that, the greater the chance we'll find something in a false positive conclusion. An example here is, does the benefit of treatment depend on menopausal status in a cancer trial, the stage of the disease, the age of the patient, and so forth? In an AIDS trial, we might ask, does the benefit of treatment depend on gender, age, initial CD4 counts, race, and so forth? So the analysis of a trial in the subgroup results in separate statistical tests for each of those subgroups. As a result, the probability of false positives or claims and conclusions arising from the analysis will increase. So the dilemma is, on the one hand, we want to ask a lot of subgroups. In fact, you can quantify this. If you have one question and you use the conventional statistical tests, by their very definition, there's a 5% chance of a false positive, a false claim. If you do 2 subgroups, that false positive rate increases to 9.7%. 3, it's 14%. 4 subgroups is 18.6%, and 5, 22.6%. So as you can see, as the number of subgroups increases, the false positive rate increases dramatically. We would not be comfortable with false positive rates of 10, 15%. In fact, we'd like to have it much less than 5%. Again, this issue of subgroups and continually examining the data. A very classic example comes from a study called the Second International Study of Infarct Survival, or ISIS-2. It was a 2x2 factorial design. We'll examine that in a later lecture. But in one study, 2 questions were asked. How does aspirin versus placebo compare? And how does a clot-busting drug called streptokinase versus placebo compare on clinical outcome? The vascular and total mortality in patients with an acute myocardial infarction were the 2 primary questions. The individuals who conducted the study went to look at some subgroups and to illustrate what can happen if you overdo the use of subgroup analysis, compared patients who were either a Gemini or Libra astrological birth signs. They found that they did somewhat worse than those on aspirin, while all other signs and overall results were impressive and highly significant in favor of aspirin. Well, it would be perhaps a stretch to explain why those 2 particular astrological signs did worse when all the others did better. So you can get strange or perhaps implausible results if you continue to examine subgroups in great number. Because of the concerns for overuse or perhaps abuse of subgroup analyses, we've decided that we need to write down some rules for how subgroups should be utilized. First, they should be stated in advance in the protocol, at least the ones that are key. We should limit them in number because the more we do, the greater the chance of a false positive. Whatever we do, we should interpret them cautiously in a qualitative sense. And for me, the main benefit of looking at subgroups is, are the results consistent in a biologically or medically plausible way? We can use subgroups to confirm a previous question. For example, does the age group under 65 have the same benefit as over 65 in a population given the drug metoprolol? We can use subgroups to generate new hypotheses in some future trial. And thirdly, we can examine the consistency of the primary outcomes as well as some of the secondary outcomes. Consistency is what we're looking for in results of any trial. In the MERIT heart failure study, a trial in chronic heart failure patients comparing metoprolol versus placebo, it was randomized, placebo-controlled, double-blinded study. It had a 2-week, what we call, run-in period, where patients were asked to comply to a tablet that turned out to be placebo, 2 weeks but the issue was would patients comply to the procedures. 3,991 patients were entered, and the trial was terminated early. There was a mean follow-up of about 1 year for the study. As you can see from this slide, the two mortality curves from the MERIT trial are displayed, placebo versus metoprolol. Two p-values are portrayed. One is adjusted for the fact that the trial was analyzed several times during the course of its follow-up. The other one is just the ordinary p-value, but both of them are highly significant. These curves indicate that there was a 34% reduction in mortality over the period of follow-up of about 18 months. This result was substantial enough, convincing enough, that the trial was terminated early. Now, if you examine the subgroups in MERIT, you will notice that there's a certain amount of consistency. Let's look at the graph more carefully. What's plotted is the relative risk, the mortality rate in the metoprolol group to the mortality rate in the placebo group. A rate less than 1 would be good. A rate higher than 1 would be bad for the therapy. As you can see, most of the symbols that are plotted lie to the left. These symbols represent the estimate of the relative risk and its confidence interval. So the boxes represent the estimate, and as you can see, all the boxes are to the left. And the confidence intervals, many of them exclude 1, which would suggest that even within the subgroup there's significance. We usually do not expect or design trials to have subgroups being significant, but nevertheless you'll see that a few are. What I want to point out here is the consistency of those results across a series of risk factors, different classes of New York heart failure from 2, 3, and 4, the ejection fraction, the etiology, smoking status, gender, history of MI, diabetes, hypertension, and so forth. So a great deal of consistency in these subgroup results. However, let's examine yet another subgroup, that is region. What's shown here in this graph is a similar setup of plotting relative risks, the estimates, and their confidence intervals for various countries. We've plotted for total mortality, for mortality or hospitalization, or for total mortality and heart failure hospitalization only. The bottom line shows the overall results across all countries being favorable for mortality, hospitalization, or mortality and heart failure hospitalization. However, if you examine countries, you notice that there's some greater variation. Most of this variation is due to the fact that there's smaller numbers of patients in each of these studies. But interestingly, especially to the regulatory agencies, was that mortality for the U.S. was neutral or slightly worse. For mortality and hospitalization, it was favorable, and for mortality and heart failure hospitalization, it was favorable. However, the fact that the mortality in the U.S. was neutral or slightly unfavorable caused a great deal of discussion and concern. It seems that given all the subgroups that were compared and all the countries that were compared, that this particular one subgroup of mortality in the U.S. is likely due to chance. However, because it's the U.S. and because of mortality, it was not easy to just ignore this. Further analysis is to detect how the interactions between countries, and there's lots of choices, which statistical model you use, which statistical test you use, how do you define the subgroups, the U.S. versus the world, or having all countries individually. These different ways of looking for interactions came up with slightly different answers. We talk about subgroup by treatment interactions in two ways. We talk about qualitative interaction, which means that the treatment effect is different in direction. Quantitative interaction, it's different, maybe in the same direction, but of different magnitude. It's very difficult statistically to test for interactions. And even if the statistical tests are significant, we still must be cautious in their interpretation. Let me give you an example of that. There's a trial called PRAISE 1 of amlodipine versus placebo in a class of 2 and 3 heart failure patients. Randomized, double-blind, placebo-controlled, where mortality and mortality hospitalization are the outcomes. This trial was stratified by etiology, that is ischemic heart failure or non-ischemic heart failure. 1,153 patients were randomized. Here are the results for the overall PRAISE 1 mortality. As you can see, there's a separation between amlodipine and placebo as the months of follow-up, but it was just short of statistical significance at the 0.05 level. However, this difference, which is examined in detail here in the Kaplan-Meier curves of the survival, this is the ischemic group. You see no difference. The non-ischemic group, you see the difference at significance level it was quoted. What's problematic about this case is that the outcome was expected to be in the opposite direction. That is, if there was an effect, it would be in the ischemic population, perhaps in the non-ischemic. But to see no difference in the ischemic population and this effect in the non-ischemic population was opposite to what was expected. So a second trial, confirmatory trial, was started called PRAISE 2 in the non-ischemic strata only. Again, amlodipine versus placebo, the identical protocol essentially, randomized, double-blind, placebo-controlled, 1,653 patients in the non-ischemic population with mortality as the outcome. In contrast to the PRAISE 1 results, where the non-ischemic population showed a highly significant result, in this case, in the repeat study, the relative risk was 1. That is, there was no difference. So despite the fact we had predefined etiology in PRAISE 1, it was statistically significant in the interaction between etiology and treatment, and that the result in the non-ischemic group was highly significant. In fact, we could not repeat that result. So it points out that even when everything looks good, we need to be cautious in the interpretation of subgroup results. I've shown you here the mortality results for the two placebo arms, PRAISE 1 versus PRAISE 2. Another lesson that we'll come back to in later lectures. But here's two placebo experiences back to back, same drug, same protocol, same investigators. Yet the placebo arm in the first study is different than the placebo arm in the second study, significantly so. Why? Hard to explain, but things change, background therapy changes, how physicians treat heart failure patients change, but it's very difficult to explain these results away. So to summarize the subgroup issue, we could ignore subgroups and only look at the overall population. Probably that would not be satisfactory. Better yet, plan for the subgroups analysis in advance and do not what we call mine, or some people refer to as dredging the data. But even if you do that, we still recommend that you view subgroup results with a fair amount of caution. One of the more challenging aspects in clinical trials and examining questions is we obviously want to look at benefit versus risk. Risk can be assessed in part by the number of adverse events we see. We believe if we're going to use an intervention, it should have a favorable benefit-risk ratio. That is, we should do more benefit than harm. It's not always easy to specify in advance. Many variables will be measured, clinical, laboratory, and so forth. We're usually not willing or interested in demonstrating intervention to be harmful, but we may know about some adverse events from earlier trials we need to pay particular attention to. We'd have something we call a serious adverse event. Death, of course, is obvious. We may have an event that's irreversible, a heart attack, cancer recurrence, some liver function damage, or some morbidity event that requires hospitalization. There's a few definitions that define a serious adverse event. These, by the way, must be reported to the Food and Drug Administration as well as to your local IRB. So these are events you need to pay particular attention to. So serious adverse events of this type must be reported to regulatory agencies, including the Food and Drug Administration, as well as your local IRBs. So these are events that you need to pay special attention to. But adverse events in general provide a lot of challenges in trials. Do you mean short-term adverse events, or are we thinking about longer-term? Longer-term follow-up in the face of early benefit. How do you deal with that? Rare adverse events may be seen only with very large numbers of patients and with long-term follow-up. There are recent examples of short-term pain reduction versus longer-term follow-up having been indicated to increase cardiovascular risk. drugs in point are Vioxx and Celebrex. I want to point out one challenge with adverse events and the ones that are rare or low frequency. Data shown here come from the Coronary Drug Project, a trial which examined the effect of a lipid-lowering agent, clofibbrate, versus placebo. What's seen here is the two mortality curves, and as shown, there's literally no difference. However, if you were to examine the data as it came in calendar time and plotted it, you would see a certain instability in the results early in the trial. What's shown here is a graph that on the horizontal or x-axis is the time in the study, months of follow-up, all the way out to 100 plus months. On the y-axis, or the z-value scale, is the test statistic that would compare the mortality in the clofibbrate group versus the mortality in the placebo group. The way this graph was constructed, a negative value of -2 would suggest a statistically significant p less than 0.05 result, showing that clofibbrate was superior to placebo. A +2 would indicate a significant effect of placebo at the 0.05 level. Well, as you can see, there are several cases, 1, 2, 3, 4 cases, in which the p-value is very close or exceeds 0.05. Yet, as you follow the trial, it settles down to a difference, a z-value of 0, the test statistic showing no difference. Well, what's going on? Early in the trial, we have small numbers, small number of deaths. So the results are somewhat unstable. This is exactly the situation we find ourselves with most rare adverse events. We see them in a trial. The number of events is not all that many. That would suggest we're on the left-hand side of this curve. We don't know exactly how it's going to turn out. But all we have is a trial with a few adverse events. Is it real? Is it chance? Hard to tell. So, we need to examine small rates of serious adverse events. Fortunately, most serious adverse events are not so frequent. It's certainly hard to interpret small numbers of events. As I showed you in the Coronary Drug Project example, mortality comparisons early on were not stable when the numbers were small. We could easily have claimed harm or benefit incorrectly. So we need to accumulate larger numbers of events to be sure whether a serious adverse event is due to the therapy or not. And the challenge is how to get larger numbers of adverse events to examine that question. We'll talk about that in later lectures. Once we've determined what question we want to ask or questions we want to ask in our trial, the next challenge is how do you measure it? What's the response variable that you're going to use to assess your question? Well, there are some characteristics that we need our measurement, our metric, to have. The measurement should be well-defined and stable. We should be able to measure it in everybody. It should be inherently an unbiased assessment tool or metric. It should be able to be reproduced. And to the extent we can make it possible, we want that metric or that measurement to be as specific to the question we're asking as possible. Examples of response variables are shown on this slide. One trial called MILUS, a trial who was designed to examine the impact of certain therapies on reducing the size of an infarct. That was the question. How do you measure the infarct size? In this trial, methods that were available to us had to do with area under the curve for enzyme levels over time, a radionuclide imaging technique, or an EKG. There were issues of definitions of each of those, ascertainment issues, and reproducibility. For example, in this study, in order to do the radionuclide imaging, the patient in the middle of a heart attack had to be taken to a particular laboratory. Many patients in the clinical judgment or just in the logistics were not able to get to that laboratory to get those measurements made. So we had a trial in which the primary outcome, size of the infarct, had a lot of missing data because we couldn't ascertain that outcome in all patients. Not a good outcome variable. Another trial called the nocturnal oxygen therapy trial had as one of its key outcomes quality of life. Well, how do you measure quality of life? There are basic instruments such as the profile of mood or the sickness impact profile, which are psychometric measures to get at those aspects of our quality of life. One could also measure pulmonary function, or the ultimate quality of life, survival. Which one do you pick? Many cardiovascular trials, which I've already shared with you some and will certainly share more, may use total mortality, or just coronary heart disease mortality, or perhaps non-fatal myocardial infarction, or something such as premature ventricular contractions. Which variable is most relevant to the question you're asking? In diabetes trials, we talk about mortality. Diabetes is a risk factor for mortality. It also can lead to blindness, or at least visual impairment. But we also can make measures of retinopathy, degrees of problems of pathology that's occurring in the eye, or even microaneurysms. Which outcome do you pick for the question that you're asking? One of the issues that is still debated is how do we use a substitute response variable for the ideal one? Examples of this might be, can we depend on the suppression of an arrhythmia to be an indicator of a therapy working when what we really want to do is prevent sudden death? We know that arrhythmias are associated with increase in sudden death. In AIDS studies, we sometimes debated the use of T4 cell counts, measures of the immune system, as indicators of whether the therapy worked in reducing morbidity from AIDS or progression to AIDS. We often use these surrogate outcomes in the development of drugs or devices in the early phases. But the challenge is, can we use these substitutes, these surrogate outcomes, as our primary measure in our confirmatory therapeutic trials? What we've learned is we need to do this with caution. Trials are always challenged, as they should be, sometimes said to be too long, too large, too expensive. If in fact we can convince ourselves that one of these substitute, alternative, or so-called surrogate response variables is appropriate, the advantages are is we probably will wind up with a smaller study, which means we can get it done quicker. We may in fact detect the effect earlier, which means the trial will be shorter, and maybe easier. There are many examples that we've used surrogates, even to approve drugs. Lowering cholesterol without evidence of survival benefit. Lowering blood pressure without evidence of benefit for stroke, MI, heart failure, or survival. We've used bone density to evaluate drugs for their impact on bone density without evidence that that resulted in a decreased fracture in an osteoporosis population. We've approved drugs that increase cardiac function in congestive heart failure patients without sometimes testing their effect on survival. We've approved a class of drugs because they could decrease arrhythmias without evidence in survival or some other clinical outcome. And same in diabetes, lowering blood glucose levels. Well, under what conditions is this okay? A paper which is referenced here, a technical paper, but I've tried to summarize the key points. The Prentice paper examines what conditions must exist for you to use a substitute or an alternative outcome variable for the ultimate clinical outcome variable. Two conditions. One is that the surrogate, labeled S, must be informative or predictive about the true clinical outcome, labeled T. That seems obvious. But where the trouble or the failure has occurred is in the second condition. For this to be true, the surrogate must fully capture the effect of the treatment, Z, on the true outcome, T. That is, if you're going to have this as the final exam, the final evaluation, then the surrogate must tell you everything you need to know about that treatment on the patient before you put it into practice. And we have many examples where that has not been true. Despite their advantages, there are many concerns about surrogates. The relationship between the surrogate and the true clinical endpoint may not be causal, but just coincidental to some other third factor. There may be some other unfavorable effects of the drug that the surrogate does not capture. And the effect on the surrogate may correlate with one clinical endpoint, but not others equally important. Let me illustrate that with a little diagram that comes from a paper that Tom Fleming and I published in the Annals of Internal Medicine in 1996. Here we've depicted a very simple diagram. Disease through the surrogate endpoint modifies the true clinical outcome. If you intervene on the surrogate, you will intervene on the true clinical outcome. A nice, simple model that would certainly support the use of surrogates in the evaluation of new therapies or interventions. However, there are many other possibilities. We've given you 4 of them. I'll only examine the first couple. In case A, the disease modifies the true clinical outcome. It also modifies the surrogate endpoint. But the surrogate endpoint has nothing to do with the true clinical outcome. So in principle, you could modify the surrogate endpoint quite well and have no impact. Scenario B is perhaps more reasonable. That is, there's 2 pathways, one involving the surrogate endpoint and one not. The disease process can affect the outcome whether or not you intervene on the surrogate endpoint or not. So we might have a therapy we believe affects the true clinical outcome, we intervene on it, and we reduce the surrogate endpoint, but still fail to have an impact on the true clinical outcome. Scenarios C and D are just more complicated versions of that. So while we think of the simple model, in fact, more likely, one of these scenarios or others is really at play. There are many examples, as I indicated, of using surrogates that we've followed in clinical research. Let me share with you a couple of them and show what the risks have been. I mentioned this trial earlier, the nocturnal oxygen therapy trial, which was going to test whether using continuous oxygen was better than nocturnal or 12 hours of oxygen in patients with chronic obstructive lung disease. There was a series of surrogates and survival posed as the metrics of this question. A small trial by today's standards of 203 patients, two-sided 0.05 for the type 1 error, randomized, multi-center trial, and sequential data monitoring was part of it. Here I've listed some of the surrogate measures that are thought about in a population of this kind. Partial oxygen concentration, hematocrit, FEV1 % predicted, FBC % predicted, the maximum workload, heart rate, cardiac index, and so forth, down to neuropsychiatric impairment and quality of life. What I've shown here in this figure are the survival curves for the nocturnal oxygen therapy trial, comparing the 12 hours versus the 24 hours of oxygen. These 2 survival curves are significant at the p.01 level. Interestingly, while the mortality was different, none of the other potential surrogate outcomes listed were significant, except for the oxygen concentration, which is, by definition, affected by the use of the oxygen. So if we had just evaluated the surrogates, we might have come to the conclusion that 12 hours of oxygen was just as good as 24 and cheaper. Yet, had we not had the trial large enough and long enough to evaluate survival, we see that, in fact, there was a terrific survival advantage to those on the 24 hours of oxygen. Another classic example of the surrogate failure is in the area of cardiac arrhythmias. We know that cardiac arrhythmias are associated with sudden death. A class of drugs were developed to suppress those cardiac arrhythmias, and they were approved by the Food and Drug Administration for use in high-risk patients, probably appropriately so. But the drugs began to be widely used, or off-label use increased. The cardiac arrhythmia suppression trial asked the question, does suppression of arrhythmias following an MI really reduce the incidence of either sudden death or total mortality? This trial, well-designed, randomized, double-blind, placebo-controlled, 3 drug arms, 3 different drugs versus placebo, multi-center. It had sequential monitoring so it could test for early benefits or risks. It was designed initially as a one-sided test, as only to look for benefit because it was widespread use and people believed the therapy would be effective. What was not known in their mind was how effective. So there was a one-sided test for benefit at the p-value of 0.025, and we used an advisory one-sided boundary for harm, 0.025. There was a run-in period. In order to qualify for the trial, You had to go in for a small period where you were on a known antiarrhythmic drug and whether your arrhythmias were suppressed. If you passed that test, you were eligible for the trial to be randomized to one of the 4 arms. Very early in the trial, in fact, about 15% of the way into the trial, the monitoring committee, which we will bring up later in a later lecture, observed the following results. There were 33 sudden deaths on drugs and 9 on placebo. There was 56 deaths on drugs versus 22 on placebo. These results were in contrast to expectations. In fact, at the beginning, we didn't know which column was drug and which was placebo. It was assumed that the placebo had the higher rate. But in fact, when the results became substantial enough, the monitoring committee unblinded itself to which was which, and were somewhat surprised to see the fact that the drug arms had the higher mortality and sudden death rates. So despite the fact that these drugs very effectively suppressed arrhythmias, in fact, they led to an increase in sudden death and total mortality. Again, the surrogate was misleading. Here I've just plotted the results over time to indicate how fast, how quickly this emerged. On the x-axis is the percent of the way through the trial, or as it's labeled, information fraction. We'll look at that again in a later lecture. So it's time into the study, fraction of the total. On the y-axis, or vertical axis, is a test statistic. At the beginning, you have no difference, but you see very quickly, 10-15% of the way in, the results are already showing a highly negative trend. Crossing that lower boundary line indicates that this is no longer due to chance, or unlikely due to chance, and this trial was stopped for harm. Again, we'll come back to this phenomena in a later lecture. So the lesson from this is that heart failure was an increasing problem. Patients having reduced heart failure function and reduced ability to conduct their activities. There are severity stages ranging from New York Heart Class 1 to 4. Mortality rate increases with the severity class. So if you can improve the cardiac function in these patients, you might be able to improve exercise and quality of life, all very desirable things. Classes of drugs were developed and, in fact, approved on the basis of those surrogate outcomes of cardiac function, exercise capacity, and quality of life. Let me examine one trial called the PROMISE trial, a trial that was published in the New England Journal in 1991. The problem was that patients with congestive heart failure at that time had a 40% mortality in 1 year. Milrinone, a drug of the particular class, was known to increase cardiac contractility. It was approved, in fact, because it improved cardiac output, exercise tolerance, and symptoms. The question was, does milrinone increase survival, reduce mortality in this class of patients of congestive heart failure? The trial was designed to be randomized, multi-center, double-blind, placebo-controlled. Patients in class 3 or 4 were utilized. A design with a 5% type 1 error significance level, 90% power to detect a reduction of 25% in mortality. We'll examine later some of the pieces of that as to why that's relevant. 1,088 patients were randomized, a trial with milrinone versus a matched placebo, and they got all the standard of care as background. Well, in this study, this slide indicates, the 2 survival curves for the placebo group and the milrinone group. And as you can see, the placebo group is having a better survival experience than the milrinone. In fact, the trial was stopped early because of this increased mortality in the milrinone group. This is despite the fact that this drug improved cardiac function, exercise tolerance, and quality of life. Again, those surrogates failed us. And finally, an example of osteoporosis. We know that bone loss in postmenopausal women leads to increased fracture rates. Fractures, especially hip fractures in these women, has high morbidity and mortality. Sodium fluoride stimulates bone formation and increases bone mass. The hypothesis was, will fluoride treatment decrease rate of vertebral fractures? So a trial was designed, randomized, double-blind, placebo-controlled, 2,000 postmenopausal women, all getting calcium supplementation. The results that were observed was that, in fact, the fluoride did increase bone density by 35%, both in the spine and the femoral neck. It increased bone density by 4% in the wrist. Despite that improvement in bone density, the vertebral fractures were actually higher on fluoride, significantly so. 163 vertebral fractures on fluoride versus 136 on placebo. Even the non-vertebral fractures were higher on fluoride, 72 versus 24, both significant. So fluoride concluded not effective as a treatment for postmenopausal osteoporosis. Again, the surrogate of bone density did not indicate the true effect of fluoride on the patient's ultimate risk. So, conclusion of surrogates is that they play a very important role in the development of devices and drugs and are needed. But treatments may affect more than one mechanism. Surrogates do not reliably predict treatment on true clinical outcome. And even if you have success in a given field, that doesn't mean the next study can depend on the same surrogate. We've come to the conclusion that reliance on surrogates, despite their advantages in earlier phases, should be minimized in the ultimate pivotal definitive phase 3 trial. So let's examine what's the study population. We have in mind a general population that we see in our clinics. But to conduct a trial, we need to restrict that population to those who are eligible, those patients who are not contraindicated to the therapy we're studying, or are at such high risk that this is not a trial that's appropriate for them, and so forth. These eligibility criteria then restrict the general population to what we call a study population. That study population then is defined by the protocol's entry criteria, including the inclusion and exclusion pieces. Now, it turns out that not everybody will show up and volunteer and enroll in your study that's defined by your criteria. So we have what we call the study sample, the people who show up and whom we get to observe. That study sample can be different than what you had in mind as defined in the protocol. So as we move from the general population to the study population in the protocol to what actually shows up, we need to keep in mind who it is we're studying. When we get done, we have some inferences we would like to make. We would like to talk about the population at large, but what we have is the sample of patients who are in the protocol. So we can only make inferences about people who look like the ones we studied. That is what the statistical inference allows us to do. We can, of course, try to generalize a little bit to the population that we define in our protocol, not all of whom showed up. But going back to the original patient population is a stretch. It's a large step in our inference process. How do we define the study population? Well, we have eligibility criteria. Again, we need to define that in advance. Those eligibility criteria will characterize the population that we're studying, the impact of the results, and have something to say about the ability to replicate the study. The people we study are not a random sample of the population at large. They're a particular sample. You might say they're a biased sample. There's not much we can do about that because patients have the right to refuse to be entered. Physicians may choose not to recommend a study to their patients. But our job as clinical trialists is to make sure that the study is not biased. So I want you to separate the fact that the population we are examining is not a random sample, but our job is to make sure that the study is a fair study, an unbiased study evaluating the new intervention. There's always a debate about who should be studied. A very homogeneous, tightly defined population, or a very heterogeneous or all-comer population. The homogeneous population, of course, is well defined. Heterogeneous population is less so. If we think we know something about the mechanism of action of the therapy, then perhaps having a more tightly defined population is appropriate. But often we don't know that. If our population is really homogeneous, tightly defined, and it's appropriate for how we think the drug works, then we will not dilute the results of our study by people who will never benefit. However, it's tougher to recruit because there's fewer of those people. So the heterogeneous population allows for easier subject recruitment. And finally, at the end, the tightly defined population, we can be very specific about our inferences, but the heterogeneous population is more easily to generalize. So as you think about who you want to study, you need to keep in mind the balance between a very tight population versus an all-comers population, and which is more appropriate for the question you're asking and for how much you know about the therapy you're evaluating. So eligibility criteria should include who we intend to study in advance. Considerations include the potential for benefit, who's most likely to benefit based on what we know, and our ability to detect the benefit. We want enough high-risk populations so their events will occur. But the risk is too high, then they have no chance for benefit. So again, there's a balance between getting the right risk set. Population should not have contraindications or competing risks. That is, a population who is at risk for some other disease that's likely to have its impact before you get a chance to evaluate the patient for your intervention. Also, a population is likely to comply. We'll examine the impact of non-compliance to the therapy in both the sample size lectures and in the analysis lectures. So you want to have eligibility criteria so you know who you studied, who you can make inferences to, and how to assess the risk rates so you can help design your trial. Finally, one lesson in clinical trials is that recruitment is tough. It's more difficult than anticipated. The yield is not 100%. This always is sometimes a surprise to new investigators. It's not 100% because, well, you define eligibility criteria to rule out some people. There's exclusion criteria. Physicians may refuse to enter the patient for good reasons, and patients may refuse also for good reasons. Over the years, we've come to appreciate that the yield in a trial from all the patients who you sort of see in your clinic or in your practice is not 100%, but in fact, more like 10, 15, or 20%. So that means that if you're doing a trial, you need to screen a lot of patients, 100 patients to get the 20 that you're looking for. Another lesson is that recruitment is a team effort. It's not just the principal investigator or the lead physician, but a team of nurses, data managers, and coordinators. And the final lesson is that we've learned over and over again that there is a healthy screening effect and that you wind up with a population that's at lower risk than you expected. That will have an impact on sample size, as we'll see later in another lecture. Finally, you need to be aware in your trial as to how you're doing. You need to track recruitment. Don't get the number of patients you're after. You will not be successful. What's plotted here is a time versus number of patients graph. The straight line says that was your goal. If everything worked ideally, that's how recruitment should have been. The graph below it shows a typical pattern that you get off to a slow start, you get rolling, you sort of catch up, and then maybe things sort of stop, in which case you're never going to reach your goal. So you need to track in your trial how your recruitment is going. If it's not going as well as you think, to have plans to try to fix the problem, because the longer you wait, the more impact it has on the trial and your success. So to conclude this lecture on what's the question and what's the response metrics, it's fair to say that it's difficult and sometimes challenging to precisely define the question, but it's essential that we do so and be precise and define, if we have more than one question, the priorities of those questions. It's equally important we pick the right measurement or metric to evaluate those questions. Using a surrogate or a substitute for the ultimate clinical outcome has proven to be faulty over time in many disease areas. Yet we can use those surrogate outcomes in the development process. We should be very cautious about using those surrogates in the final pivotal phase 3 definitive trial. Subgroups, of course, are part of the challenges of clinical trials. We need to use them. We should use them cautiously. In the next lecture, we'll examine what design we should use to test the questions and the metrics that we've just been talking about in this lecture. So we will examine a series of designs and their advantages and disadvantages.